Wells Pharmacy Network. Before we go any further, I do want to review the functionality of GoToWebinar. Your active participation is important throughout the session, and right now we have everyone muted to avoid background noises that may distract you from listening to the webinar. I'd like to introduce myself. My name is Jennifer Gomez, and I'm the Marketing Manager at Wells Pharmacy. I'm hosting this webinar along with Anthony Campbell, PharmD, who has over 13 years experience compounding sterile and non-sterile medications. As a nationwide compounding pharmacy, Wells Pharmacy Network specializes in wellness, anti-aging, weight management, sexual health, and thyroid and adrenal health. Our mission is to elevate compounding industry standards through a unique combination of superior service and science. Today we're going to be discussing incorporating Sermorelin and peptide therapies into your practice. And if you have any questions, please feel free to submit them on the chat section of your GoToWebinar, and we'll leave about 10-15 minutes at the end of the webinar to answer some of those. And without any further ado, I'll allow Anthony to begin the presentation.
All right, well, thank you, Jennifer, and a quick welcome to everyone here, and thank you for your time tonight. I do want to be respectful of it. I do want to get through it, and I don't want to rush through this, but if I'm going too fast, you can always contact me directly at the email, and we'll give you that information at the end. But just to get right into it, so today's talk is about Sermorelin and peptides and how it can be incorporated into your practice and what it's used for and basically how it functions. So our objectives tonight are we're going to, of course, quickly review the process of how growth hormone is released and what happens to it as we age. Recognize some of the effects that occur because of the lack of growth hormone. And then the bulk of the time is going to be on kind of learning what Sermorelin is and then how it's used and how it can be dosed and prescribed for specific patients in your practice. We do want to be familiar with maybe some current dosing protocols and, of course, answer all of your questions that we can. But without delaying anymore, let's just get right to it. So growth hormone secretion, of course, we all know that it's secreted by the pituitary gland, and it's released into the bloodstream, not so much continually, but what happens is it occurs in episodic kind of pulses. And it stimulates the pituitary to release the growth hormone, which has its effect on the liver, which ultimately stimulates the production of IGF-1. So in the younger people, these pulses are very frequent, and more importantly, they're very strong. So meaning that the amplitude or the peak, the pulse of that growth hormone stimulation is very high. So as we age, they don't necessarily decrease in the frequency, but the amplitude or the pulse significantly declines. We're going to look at that in a little bit. So I'm not going to go into a whole lot of detail with this. I just want to show you this basically to show you that it is controlled by what's called a negative feedback loop. So the more growth hormone that is released, then the less growth hormone releasing hormone is going to be produced to have its effect on the pituitary. So just keep this in mind. We're going to come back to it just in a little bit, but just want to get you a picture to know that it is involved in a negative feedback loop, and that's going to be important when we're talking about growth hormone, human growth hormone, versus growth hormone releasing hormone, or Sermorelin. So growth hormone secretion, like we said, it's in the younger, the pulses are frequent and strong, and what happens here when we're in our young years, in our puberty years, it's secreted in very large amounts. I think they measured it in a couple studies that it's about 150 micrograms per kilogram per day, and by the time we're 50 or 55, it's reduced to about 25 micrograms per kilogram per day. So that's significant. It's over 80% loss of production of growth hormone. So as you can see from the chart here, after about age 30, it does kind of level off there. So Definitely by the time in your 40s, these are the patients that would be most benefit from Sermorelin therapy. So again, this is just another chart showing the frequency and the amplitude of growth hormone secretion. So just a chart there. This is from a study done several years ago. And then lastly, of the 3 points here, these pulses, they do peak in the early morning hours, meaning that it's around between 1 and 3 a.m. Normally, that's when growth hormone secretion has the highest amplitude of the day. And as we can see here, there's a chart comparing young people with old people. And if you look at it closely, you can see that the frequency of the pulses is still very similar, but the amplitude or the height or the peak or the amount of growth hormone that's secreted is significantly declined. So this kind of gives you kind of a picture in your head of the significance of the loss that we have. So we have the word somatopause. It's kind of come into play. We have menopause and andropause. So what's somatopause? So just to break it down, it's from the Latin. It just means the entire body, and then of course pause to come to a stop. So the entire body of the organism is beginning to slow down or come to a halt. And what this is the first sign that you have neuroendocrine decline. Its symptoms and signs are the reduced production and secretion of growth hormone compared to that when we're young. So the symptoms of this somatopause, I go through each one of these, but if you look at them, they do mimic or they mirror there's a clinical distinction of adult growth hormone deficiency. So these are the things that we see as people age, and it's also the things that closely resemble those patients who do have adult growth hormone deficiency. So they see things like decreased lean muscle, you got your loss of skin elasticity, decreased bone density. They do recovery from injury or exercise is either prolonged or sometimes inhibited, and the impaired glucose tolerance or insulin resistance occurs in some of the older people because of all this. So the hypothesis or the thought is that, well, if growth hormone replacement therapy is of benefit for these patients to have adult growth hormone deficiency, then it should be of benefit for patients as they age to replace growth hormone. So a lot of practices, what they'll do is they'll give omnitrope or somatropin, and that's the recombinant human growth hormone therapy. Now this has many advantages, and there's been many studies in patients with adult growth hormone deficiency that it's been proven to be very effective. It does decrease fat mass volume. It does increase lean body mass and skeletal muscle. It increases exercise capacity, cardiovascular functions. It increases bone density and overall quality of life in a number of patients. And there's a number of studies where this has been shown to be true. Although its use for anti-aging purposes outside of controlled studies is currently prohibited by U.S. law. So without the distinct diagnosis of adult growth hormone deficiency, and it's not an approved use of it, but that certainly doesn't prohibit its use in a number of patients. But a lot of the disadvantages in these studies, although they did have a very high number of advantages, there were a number of disadvantages associated with its use. About almost half of the people that used it did have some sort of clinical edema associated with them. They have about a quarter of them had joint inflammation or myalgias, and about 10% of them developed carpal tunnel, with a number of them also developing hyperglycemia, hypertension, glucose intolerance, and hyperinsulinemia. So as you can see, there's a lot of advantages, but the potential risks or disadvantages are equally, if not more, alarming. So we want to look at this and see what we can do outside of this. So a lot of these disadvantages is, in the literature state that they were due to inappropriate dosing, or that they were given too much. So this is important because this is where growth hormone releasing hormone, or Sermorelin, has a distinct clinical advantage over using human growth hormone chronically in these patients that you want to increase growth hormone in. So the advantages of growth hormone releasing hormone, or Sermorelin as it's known, what happens is these, when you provide this, it stimulates the body's own production of growth hormone. And that's done by, it's controlled by the pituitary and the negative feedback mechanism that we looked at earlier. So instead of getting these growth hormone injections that produce what's called this square wave, or you get a sudden burst and a prolonged peak of the super physiologic dose of growth hormone, what happens when you give Sermorelin, or growth hormone releasing hormone, is that it causes your body to increase the amplitude of those already normal physiologic pulses that are occurring. So it's short bursts that occur normally throughout the day, and it does more accurately reflect the normal physiologic action. So what happens is you get these short bursts, these short times of exposure. So tachyphylaxis is all but nearly impossible to achieve with Sermorelin. There is no superphysiologic exposure of growth hormone because it is controlled, again, like I said, by this negative feedback. So and the normal feedback regulation by IGF-1 is preserved. This does offer some buffering against this potential overdosing that was seen in these patients in those studies where they had the side effects because they were overdosed, unintentionally of course, but nevertheless this is where Sermorelin has the advantage over growth hormone. So GRF144, that's growth hormone releasing factor, that's your full chain growth hormone, and then GRF1 through 29, that's the active portion of growth hormone releasing hormone. So without giving the full chain of amino acids, they do find that the first 29 amino acids are all that is necessary to elicit the clinical effect that is experienced by growth hormone releasing hormone. So it has a number of benefits, and it does it improves sleep. The half-life of this is very, very short, you know, between 5 to 10 minutes, I think, in a lot of studies that they'll say. Other forms of growth hormone releasing hormone, they do have modified versions. You know, they go by the name CJC 1295, and they do have it with a drug affinity complex or without a drug affinity complex. And a number of physicians have asked me, can you get this drug with this drug affinity complex, because the half-life is significantly longer. As you can see, with the drug affinity complex attached to it, it does have a half-life of days, as opposed to you know, minutes with the Sermorelin. So why is this not, you know, the standard? Why are we talking about Sermorelin and not something that we can just use this and maybe inject it, you know, once every 3 or 4 days, as opposed to daily? And we're going to talk about that, I think, in the next slide, where the growth hormone releasing hormone pulses, they don't last continually. They're not something that goes on and on and on and on. They do happen in a pulsatile fashion, and they only last for a number of minutes anyway. So once you have that peak and your body releases that growth hormone, there's not going to be another pulse, you know, for several hours. So providing a drug or a growth hormone releasing hormone that has a half-life longer than what is physiologically possible for your body to secrete, it doesn't really make clinical sense to do that. So here we are with Sermorelin GRF 129. It's the biologically active analog of growth hormone releasing hormone. It's like I said, the first 29 amino acids of the complete sequence of it, and it is synthetically prepared. So this isn't something that's produced, from a biological source and extracted and then purified. This is something that's synthetically prepared from highly purified sources, and the chemicals that are used to make the final product, they do have FDA oversight over those facilities. The history of Sermorelin, I get asked a lot, is Sermorelin commercially available, or is it something that's FDA approved? And the answer, I guess, would be kind of yes and no. Well, yes to the fact that Sermorelin was a commercial product back in the late 90s, 1997, I believe it came on the market. It was sold under the brand name GHRF, G-E-R-E-F, and it was used in children to increase growth hormone. It was subsequently taken off the market in 2002 because it just couldn't compete with growth hormone, and this is due to the fact that children, as we know, need a lot more growth hormones. Children that are growth hormone deficient need a lot more growth hormone than what can be provided by Sermorelin. But that fact alone is what makes it so valuable in the age, because while we do want to increase growth hormone in the aged person, we're not looking to get them to be at the levels they were when they were 13, 14, and 16 years old. We're looking to get them just a little bit above, maybe in the late 20s. So that's where Sermorelin is able to do that, and that's why it wasn't very effective in the children subsequently taken off the market. The chemical, because it was used in a commercial product, is able to be compounded in a number of forms. But as you probably know, any compound is not FDA approved. But anyway, so Sermorelin dosing. So how do we dose this? So there is really no standard dosing in the literature anywhere. There's a number of studies that have been used, and they go all over the board from as little as 100 micrograms. I've seen doses in clinical literature up to 4 milligrams that have been given. Most of the literature uses a range between 300 micrograms, maybe 500, up to 1 milligram. But clinically, what I've normally seen are doses from 100 to 300 micrograms, and they produce the same effects as the higher doses in the studies. So younger patients are going to be your ideal patients, of course, with a good body composition. They're relatively lean. They might have a little adiposity going on from being older, and the typical dosing for them might be 200 to 300 micrograms given subcutaneously an hour before bedtime. Now, why 1 hour before bedtime? Well, ideally what you'd want to do, and the jury's still out on whether or not what is more effective. There's been a number of studies comparing this, and nobody has come to a conclusion yet, but growth hormone is secreted multiple times throughout the day, with the largest being at night. So ideally, yeah, you'd want to give Sermorelin probably 3 times a day, separated away from meals, to get probably the best effect. But that's inconvenient, maybe unrealistic. But what we find, instead of giving 100 micrograms 3 times a day, well, they'll just give the 300 micrograms once before bed, where the stimulation of the growth hormone is the largest, right after sleep. So your ideal patient is going to be, it says here 35 to 70-year-old, and that, that's generally the case, but there's a lot of exceptions within that age range. And the good general health with the BMI, of course, less than 35, or they're not, clinically obese. So those patients that might have a little bit more abdominal fat or increased weight, their BMI might be around 30, maybe 31, 33. They're not obese, but they're definitely not, at their ideal body weight. So what do we do with these people? Well, one trial thought, starting off with human growth hormone to kind of get a jump start on it, right? So they used 1 to 2 units of growth hormone just for a short period of time, and then you follow that up. You cease the growth hormone and then begin Sermorelin. Now, of course, you're going to get a significant drop because you're giving growth hormone directly, and then all of a sudden you're stopping that and you're giving Sermorelin, which relies on your pituitary to secrete that. So a few of the studies have shown that this to be successful in those patients. The reason for starting off with growth hormone, like I said, just to kind of give a quick bolus, kind of give a loading dose, if you will, to get the body kind of going. So it doesn't take nearly as long for the Sermorelin to produce the effect that you're looking for. And then for women, or obese patients, and for women, it's really the stipulation for women is those women that are taking oral estrogens. They're going to require a little bit more because estrogen does blunt the effect that that growth hormone has upon the liver to produce the IGF-1. That we're looking for, I guess, or that we're monitoring for efficacy. So it's going to be the same as the previous slide, but you're going to maybe use a little bit more. And on the next slide, these are just recommendations, really, about the BMI. These are rough guidelines. If you don't really know where to start, you get somebody that's really lean, maybe 18 to 24 BMI. They might, they're not going to need 300. You might even get away with, 100, 150 micrograms, as opposed to the 300. So the heavier person, of course, might need a little bit more of the Sermorelin. So the absolute contraindications, who are these patients that we don't want to put on Sermorelin? So the absolute contraindications in the literature, are these patients with malignancies, of course, if you're pregnant, or any type of proliferative retinopathy or benign intracranial hypertension. So in those patients, you do want to seek alternative methods of maybe through amino acids of some type that you could help increase growth hormone. So the adverse reactions everybody asks about, and I get reports from a number of patients who don't have any adverse reactions. They don't experience anything. They barely even notice anything after the injection. And then I get patients who will say that, oh my gosh, I got a big red patch. I get all itchy all over. What's going on? It's itchy for like a day. So it is all over the board. But these side effects with this Sermorelin come from the clinical trials that were done with the commercial product of Sermorelin that I mentioned earlier. So 16 to 20% of your patients are going to have that localized reaction, and that's not necessarily attributable to the product. I get patients to say, I got a bad batch, I want it replaced because I got a big red itchy patch and I think something's wrong with it. And that's more of a normal and expected adverse event or side effect of the medication as opposed to a bad batch. So other side effects, of course, are the headache, the flushing. Patients get dizzy. They might have a little bit of trouble swallowing, and the urticaria or the itching is in there as well. So in the literature, they do report that I think there was one report of antibody formation, but it didn't have any significant clinical effect. But it would be maybe a cause to discontinue it and then not re-challenge the patient. So then we get into to the peptides. So what are GHRPs? Growth hormone releasing peptides. So there's a number of them. Ipamorelin, it is potent. It's the weakest of those growth hormone releasing peptides. Then we have GHRP6. It's very potent in itself too, and then GHRP2. So these are two that we currently utilize here. We don't utilize Ipamorelin, but GHRP2 and GHRP6 are two that we incorporate into our products very regularly. And we do that because they do not have an effect on the cortisol or prolactin. like the hexarelin does. And I've had some prescribers ask if we can get hexarelin because it's the most potent, so I want the most bang for my buck. Well, that's not always the best route to go. You do have to deal with you know, some of the side effects of that. So we do find clinically that GHRP2 and 6 do have the best effects without exposing the patient to any potential adverse additional side effects. So can you give them by yourself, or can you give them with Sermorelin? Yes, to both. So currently you can give it by itself. It's more potent than Sermorelin at producing a release of growth hormone, but all of our formulae items are currently combined with Sermorelin partly because you don't want to you give too much of these GHRPs, you do find that you do get tachyphylaxis with these products, meaning, or you get sensitivity to them. So, so what happens is you want to just use a low effective dose at the same time that you want to use Sermorelin. So what happens is you get the effect of Sermorelin plus the effect of the GHRP, but that's not always, you know, 2 and 2 is 4. You're going to get 2 and 2 equals 10 or something, and depending on your dose of GHRP. So it is not additive. You know, it is much greater than that. You get an exponential increase. So how do we dose GHRPs? So there hasn't been a whole lot of studies on them that in the clinical literature that I could find when I was digging through things, but I do find some that will say that there's a kind of a saturation point with the GHRPs at about 100 micrograms, and definitely no more than maybe 150 or 200, certainly. So we keep a lot of our ratios of our GHRP2s and our 6s so that when you reconstitute it and you're given your dose of 200 to 300 micrograms, your dose of GHRP kind of falls within that 100 to 200 microgram range. You know, adding more certainly isn't going to get you twice the effect. It's one of those things where you add more, you might get a little bit, and then you add more, you might just get a little bit more on top of that. So you don't want to give more GHRP thinking you're going to get more of an effect. You're just going to use more of the drug and spend more money on something that might not be clinically advantageous. So we typically want to keep our doses around 100 up to 150. Like I said, because they do tend to get sensitized. So what you'll see is patients who respond to the Sermorelin GHRP therapy, you know, very well for the first month to 6 weeks, maybe 2 months even, and then you find, well, my IGF levels are kind of stagnant or they're actually dropping. So what we tell those patients in those cases, and those are the patients that are usually using it every day, nonstop, day in, day after day, is try to revise maybe either the dose of GHRP that you're using, or try an alternative protocol where you're taking a little drug holiday of sorts. So you're going to have you know, 5 days on and maybe take the weekend off, and then return to 5 days on and then 2 days, or just 21 days straight and then take the last week of the month off, and then kind of give your receptors a little bit of time to reset, to resensitize, and then when you restart your therapy the following week, you know, you're going to have a little bit more of effect, and that way that can keep the receptor sensitized to that. So the conservative protocol, like I said, is 100 to 200, 5 to 7 days a week. You can do it 1 to 3 times a day. If you do that, you decide that that's what you want to do, then just be sure that you separate your dosing by about 3 to 4 hours, and make sure it's away from meals by a couple hours as well. And the MDD there is a multi-day dosing. So, so the frequently asked questions. I do want to kind of, I don't know what time I have here, but you know, it's getting limited. So this will kind of show you how to reconstitute the vials. I don't want to go through this. I think these slides will be made available to you. So these are calculating the micrograms per dose. I know it can get a little confusing, and we try to make it real easy here for you to kind of look at and to see how you can best get your dose and what size vial to buy, and do I need to buy the 9 milligram vial, or what about this 15 milligram vial? That sounds real great. Well, you might not need a 15 milligram vial if your dose is only going to be 100 micrograms or 200 or 300 micrograms for your patient. You got to keep in mind that the vial can only be used for 28 days before it has to be discarded. So you can't get a 15 milligram vial and then dose 200 micrograms and use it for a couple months. And this will give you some information on what's included in the shipment. And these are some examples of some formulary items that we have. And on here you can see that the doses of Sermorelin also combined with the doses of GHRP2 or GHRP6. And sometimes we combine both 2 and 6. And you can see the doses on there. Now these are the 3 milligram vial. You can see what that equates to in days supply, and the 6 milligram vial as well. And most of those are reconstituted with either 6 or 9 mLs, unless they're otherwise noted on that slide. We do have some different oddballs there. So how long does this patient have to use it before they should see results? I do have to say you have to have a patient that's committed to stick with it without stopping for at least 90 days in order to see any benefit. So this is something that they very well feel a benefit after a week, but to get the continued benefit, to see it fully, they do have to commit to it. So if they don't see any changes, well, they need to have your labs measured, find out where you're at. Of course, before you do any of this, you do want to get baseline measurements of IGF-1 if that's what you're going to be measuring as a marker for therapy. So I think a lot of these will answer your questions, and you can read through these. I do want to kind of get through them just so I can answer your questions. You can have that. I didn't cover anything here. You can see on there that we do purchase.
We have a few questions, Tony, that rolled in, and actually one that just came in kind of does go over some of the formulations we have. Someone does want to know why the addition of theanine on the GHRP2 vial.
Okay, that's a good question. I know we have one that does have the theanine in there. So the reason for theanine is because it does have a calming effect, and it does promote sleep that we find. So we put that in there as a kind of to help relax, because it is given before bedtime. There are a number of clinics, patients that do use this formula because they like that. A lot of patients will find if they give Sermorelin that they get they feel jittery. They have those side effects that were noted earlier, that they they have trouble breathing even, or things like that, that they just can't sleep. Patients will describe those. So this is kind of put in there just as an effort to promote a sense of wellness, relaxation, and promote how healthy sleep, and that's why that was in there.
Okay, great. Let me start going through some of the questions that have come in. So someone said that some literature recommends omnitrope dosing in the morning in order to avoid negative feedback. And is this true for Sermorelin as well?
Right. So yeah, that's true. And they typically do find that growth hormone would be best given in the morning. Sermorelin, because of the way it works, because of the way growth hormone is, you're giving that growth hormone directly, so you have an abundance of it right away, and it will affect that negative feedback. Your growth hormone is typically peaked, like I said, in the early morning hours. By the time the morning comes around, they should be a little lower. So giving the Sermorelin, it really isn't affected too much by the negative feedback, because what you're doing is providing the hormone that stimulates the pituitary to release growth hormone. You're not giving growth hormone directly. So while it is affected by the feedback loop, it's not affected in the same way that growth hormone is affected. So while you could give Sermorelin in the morning, you don't necessarily have to, as you would the regular growth hormone.
Now, what time of day is best to check for IGF-1, and then what sort of changes might you see with the IGF-1 levels?
I think if you're measuring IGF-1 levels early in the morning, you know, as early as you can, you know, upon waking, and then just remember to stay consistent with that. So I think you would want to continue that, so you're not testing in the morning one time and the next time test it at, you know, 3 or 4 in the afternoon. So what kind of changes would you see with the Sermorelin? I think that might be the question. If not, you can tell me. But right away, initially, you may or may not see any changes within the first week or two of IGF-1 levels. I've had a few patients, even physicians, who've used Sermorelin, and they've seen that their IGF-1 levels rose within the first couple weeks, even. So, but again, there's, you know, I don't know what time of day that they're comparing their levels, or if they're doing their initial baseline level was in the afternoon and then their subsequent one was in the morning, or what, you know, all the factors that are involved in raising. But, you know, if all things are consistent and equal, then you should see an increase in IGF-1 levels, certainly within, I would think, the month, definitely within the 90 days that is recommended.
And now, can you use testosterone and Sermorelin?
Sure. I mean, not at the same injection, just because, you know, they're different. They won't combine well. But I mean, if patients on testosterone therapy, they can certainly be on Sermorelin therapy as well. Yes.
And then, how do you recommend, or how long do you recommend for someone to be on Sermorelin therapy, and how long does it stay in their system?
Right. So what you're doing is you're providing the hormone to tell your body to stimulate it. So it's kind of like, you know, you're squeezing the juice out of an orange. So you should definitely give it at least 3 months trial before deciding that it's not working, or you decide that you might need to increase the dose or change therapies. It's going to continue working, you know, as long as you use it, because you're continually providing the hormone to the pituitary. You know, once you stop, you know, you may have a couple of days where it'll still have an effect, but certainly to see the continued effects, you'd have to continue using it. But you know, keep in mind you're using it over a number of years. You know, over those number of years, you're still aging, so your pituitary is aging as well. So you may find that it's working, you know, not as well as it did, you know, 4, 5, 7 years when you started. But you know, you can attempt to, you know, just use a little bit more, or increase the dose, or you know, try other means of therapy. But you know, keep in mind also that we're not just trying to, you know, get our IGF-1 levels up. You know, we're just not trying to treat this number, and I just need to give a little bit more to get it in this normal range. You know, you got to, of course, look at the patient, look at the quality of life that they're having, their abilities and their functions that they didn't have when they started therapy compared to what they're able to do and perform now. And that doesn't always mean that their IGF-1 levels will be, you know, elevated, but you know, they may feel and have the you know, the benefits of it, you know, without trying to pump that number up. But you got to take the whole clinical picture, I think, rather than just trying to pump up a number. But I think we all know that anyway. But
now, do you have to follow with the IGF-1, and then what is the target range that you aim for with IGF-1?
right. So that really varies by the age of the patient, and there's there's a number of graphs and charts available, openly online. Just a quick Google search for clinical literature for normal IGF-1 levels would get you those values, but I think you would find that you can't. It's hard to define normal. There's published clinical data out there, but to really look at the patient and find out what their baseline is, and then try to determine a realistic goal for them to achieve. Certainly, if their IGF-1 level is at 100, and you're trying to get it, and they're 70 years old, and you're trying to pump it up beyond something that's realistic, then you got to think what's realistic for that patient. So it's not going to be a cookie cutter thing where every patient that's in their 40s is going to get this dose. You really got to take each clinical patient individually and set goals for those individual patients.
Now, someone said that their patient had a lot of acne with a small dose. Is that something that you see often?
They had acne from Sermorelin? No, I haven't seen that. I've got a number of reports here, or clinical literature and studies I've read, but acne wasn't associated, or at least described or listed in any of the adverse events in any of those studies. So I don't know if that's associated with Sermorelin, or it could be just one of those outliers that are out there, but it hasn't been anything that I've seen, but that doesn't always mean that it isn't possible.
Then someone said, are you also recommending other anabolic peptides?
Am I recommending that? We're only talking about Sermorelin and GHRP at the moment. If there's other anabolic peptides out there, that would be, I think, a topic for a different discussion. But I'm not recommending those. I'm not familiar with I'm sure there are a number of them. I haven't researched those quite as extensively as Sermorelin and GHRP, but I think as for promoting what we're doing here is educating you all for the use of these specific peptides. If you want to learn more about the other potential peptides that are out there, I think that would be it's certainly available to do. But it's not what we're recommending here, no.
Now, someone wants to know, is there any harm in using Sermorelin even if your IGF-1 is in normal range?
Well, I think you'd have to, if your IGF-1 level is normal, and you want to put somebody on Sermorelin, you'd probably have to ask, why are you putting them on Sermorelin? If it was for the benefits of some of the physical benefits that maybe they're lacking, or to increase lean muscle mass or something, then you can certainly still provide growth hormone. I don't think it would cause anybody. It wouldn't cause harm. You would certainly have to monitor that patient, assuming they were in good health, to begin with. But if a young 40s individual came in and their IGF-1 was normal, and they found that they're just increasing adipose tissue, they got decreased bone density, decreased lean muscle, and you want to put them on Sermorelin, that's certainly an option. But you do have to keep in mind to look at the rest of the patient. But there wouldn't be any contraindication to that. No, that certainly would still be a candidate. Yeah.
Okay, great. Well, I think this is going to wrap up our Q&A section. So thank you so much for Tony. That was so informative. I'm sure everyone really appreciated it. If we didn't get a chance to answer any questions, or any questions come about, feel free to email us at info@wellsrx.com. That's info@wellsrx.com. therapies.com, and we'd be more than happy to answer any questions that you may have. This presentation will be available along with the slides if you are interested in seeing some of this information again. So, Tony, thank you so much.
Thank you all.
Bye.